Meni je pravo zadovoljstvo što i ove godine učestvujem na tradicionalno izuzetno važnom sastanku o srčanoj insuficijenciji. Žao mi je zbog formata, ali se nadam da ćemo se uskoro vratiti u normalne okvire. Posebno mi je zadovoljstvo što mogu da u ovoj sesiji pozdravim čuvenog profesora Baxa i zato ću preći na engleski. Heart failure requires extensive evaluation with non-invasive imaging modalities to detect etiology and the stage of disease, choosing the best therapeutic option and monitoring therapeutic response. Nowadays, an integrate multimodality imaging approach is paramount for optimal diagnostic and prognostic evaluation heart failure patients. This session is dedicated to non-invasive diagnosis of heart failure, and it is my pleasure to invite Dr. Milinković. He will present his patients with heart failure, and I'm especially pleased to announce Professor Bax from Netherlands. He is one of the leaders in world cardiology and a former president of European Association of Cardiologists. He will tell us something about diagnosis of heart failure focused on etiology. Here is Professor Maksimović. She is a leader in MRI in Serbian region, and I think that it's time for Dr. Milinković.
Poštovane kolege i koleginice, učesnici Kardiosa 2020. Kao uvod u sesiju neinvazivnih metoda u detekciji srčane insuficijencije predstavit ću prikaz slučaja. U pitanju je bolesnik 36 godina star, koji je po profesiji radnik, koji je došao na prijem urgentnog centra sa bolovima u grudima koji su se pogoršavali prilikom ležanja, a pojavi tegobe je prethodila groznica i respiratorna infekcija nekoliko dana pre toga. U ostaloj istoriji nije imao značajnije komorbiditete, ali ima faktore rizika, bio je pušač, gojazan, pozitivna porodična anamneza za kardiovaskularne bolesti, fizikalni nalaz normalan, uredan pritisak, na rengenu ništa značajno, ali elektrokardiografski jedna difuzna sedlasta mesta elevacija, patognomonična za perikarditis. U laboratorijskim analizama povišeni znaci inflamacije, znaci miokardne lezije, zajedno sa nešto povišenim BNP-om. Odmah je uređen holter i na njemu nije nađeno ništa značajnije od aritmije. Prvi eho koji je uređen kod bolesnika je pokazao da postoji manja inferiorna i septalna hipokinezija i nešto manje poremećena funkcija leve komore, što takođe može da se javi u sklopu jednog fokalnog miokarditisa. Međutim, kada je uređen magnet srca u sklopu protokola za miokarditis, detektovano da postoji hiperenhancement na zonama 5 i 11, dosta suspektan za ishemijske promjene. I sada je ta inicijalna dijagnoza koja je bila miokarditis više naginjala da može da bude jako infarkt miokarda, zbog čega je uređen koronarni angiogram koji je pokazao da postoji jednosudovna koronarna bolest kod bolesnika. I u istom aktu je bolesniku implantiran drug-eluting stent u ovom granu koronarne arterije i bolesnik sa adekvatnom terapijom sad za anginu i za perikarditis otpušten kući. Da magnet može da pomogne prilikom jedne diferencijalne dijagnoze bolesti u kardiologiji pokazala je studija iz 2008. godine u Jack Cardiology Imaging koja je analizirala jednu korelaciju između zona 17 zona, tačnije miokarda i perfuzije, odnosno vaskularizacije tih zona i utvrdila je da u određene zone koronarnih arterija postoji veća ili manja korelacija sa nalazom hiperenhancementa na magnetu, tačnije konkretno u našem slučaju to je cirkumfleksa bila kao koronarna arterija sa OM1 koja pokazuje neke manje znake korelacije, ali nezavisno od toga magnet, kao što je ovaj put pokazano, je značajan dijagnostički modalitet neinvazivni u dijagnostici kardiovaskularnih bolesti. Postoji u našem algoritmu, sve je dostupniji, sve je primjenjiviji i značajne za adekvatnu dalje usmjeravanje dijagnostike i terapije kardiovaskularnih bolesnika. Hvala na pažnji.
Hello, colleagues. We're going to talk today about differentiation between ischemic and non-ischemic cardiomyopathy and what other information do you need to treat your heart failure patient. Welcome to the session. And I'm going to start with the patient example. This is a man, 62 years old, and he has in 1987 an infarction, 1988 an infarction, in 1994 the third infarction. Then eventually in 1996 he gets bypass surgery. And in 2000, he suffers a non-sustained ventricular tachycardia. He has comorbidities, he has diabetes 2, and he has COPD, and he has severe kidney failure. This is the heart failure patient of today. Now, this patient is clear, he has ischemic cardiomyopathy. But we're going to use our imaging how to differentiate between ischemic and non-ischemic cardiomyopathy. And I'll take you slowly through it. This is the same patient. He presents with reduced exercise capacities in New York class 3. He has dizziness and hypotension, and that's clear because when we measure the blood pressure, he has a pressure of 90/65 millimeter mercury, and he has a holosystolic murmur at the apex. That means that he has a mitral regurgitation. So simple evaluations show us low blood pressure. That means no good function, LV. And it shows also by auscultation that we hear the murmur, which fits with a mitral regurgitation. So that's what we know already before doing any imaging. If we have this discussion about severe heart failure patients, to determine the therapy, the information that is below here is what you need. You want to know how is your function and what is the ventricular size. You want to know, is there coronary artery disease or not? If there is coronary artery disease, does the patient have ischemia and viability? And why? Because those patients need revascularization. Then the question is, does the patient have severe mitral regurgitation? Do I need to treat the mitral valve, either mitral clip or surgical or nothing? And the other question that you have, does the patient need an ICD? If we talk about LV function and size, we know, as you see here in this paper by Harvey White, already in 1986, that once the ejection fraction goes down in the direction of 20%, the mortality goes up steeply. That is where the patient develop heart failure and eventually die. What do we do to assess LV function and size? We do simple echocardiography. On the top two images is our patient with the inferior infarction and the anterior infarction. The bottom two are other images from another patient. And you see that there we give contrast. And with that contrast, we see so much better the ventricular function. And also on the bottom right, you see that there is a thrombus in the left ventricle. So by giving contrast, you have a better contour detection. What is the left ventricle? How is the function? How big is it? And you can see these thrombi, which are often present in patients with bad ventricles. We're moving from 2D to 3D imaging, as you see here. And with the probes that we have nowadays, we can get 2-chamber, 3-chamber, and 4-chamber in one shot. And from that, we can reconstruct a 3D picture, as you see here, where you can automatically calculate the ejection fraction. We're moving with echo from 2D to 3D, but echo is the mainstay in the evaluation of LV function in your heart failure patient. Of course, we got beautiful imaging techniques such as MRI. Here you see on the bottom a 2-chamber, in the middle a 4-chamber, and on the right a short axis view. We can see the left ventricle, the right ventricle, we can see the mitral valve apparatus, we can see the papillary muscles, we can even see the trabecularization in the right ventricle. This is a fantastic technique, but how many echoes do you do per day in your echo lab? Maybe 200, 150, 100? And actually, we can never do in all these patients an MRI. So you need to be selective. You just need to use it when you need it. We can also do CT scan, as you see here. CT scan gives also beautiful pictures. This is actually a non-ischemic cardiomyopathy. And I see very carefully the left ventricle and the right ventricular function. Right ventricle is also not good, as you see here. But this comes with significant radiation. These patients will have a radiation secondary to the CT scan. That's not what you want. So basically, we like to use echo. And if we really need better quantification, we do an MRI. What do we need specifically? We need the highest resolution as possible of the images. We need to assess the ejection fraction, but also volumes and dimensions. And the exact quantification is for prognosis, but also for justification if the patient needs an ICD. If he has an ejection fraction less than 30–35%, he is entitled to an ICD. We are moving away from just visual assessment of LV function. We're moving towards this strain imaging, and that's what you see all the time now. So I'm going to take you through this briefly. Here you see the probe that I used before with the 2-chamber, the 4-chamber, and the 3-chamber assessed just in one shot. And from that, the software develops for you on the bottom right a polar plot. And that polar plot is the strain map of this patient. What is the strain? The strain that we use mostly is what we call the longitudinal strain, is the up and down replacement. And you see here at the bottom right, the polar plot, and I'm gonna now click, and you see a red rectangle on the lower right, and it says minus 20.4%. This is a normal individual. The global strain in a normal individual is around minus 24%. Let's say 19 to 21. The minus is because it's the up and down displacement. Forget about the minus. Just remember the number 20. That is normal. I'm going to give you now 3 examples. On the far right, at the bottom, is the strain map of a normal again. It says minus 19. 19, 20, 21, that's all normal. In the middle, you see a patient with a previous inferior myocardial infarction. Inferior myocardial infarction. And you see that it's all blue there. Everything is blue. And that is where the infarct took place. There is no more deformation. That is now scar tissue. And the global strain is 13.8%. And if we go one step further to the left, you see the severe heart failure patient. And the global strain there is 7%. There is no more displacement at all. How do these strain numbers correlate with ejection fractions? I would say 19% strain is about 50–60% ejection fraction, normal. In the middle, an acute infarction has on average a strain of, let's say, 14%. That correlates with a ejection fraction of about 40%. And on the far left, that's the heart failure patient with a global strain of 7. And that correlates, let's say, with an ejection fraction of 15%. So you get a bit of a feeling, how do the strain values relate to your ejection fraction? Now we're going to talk about severe heart failure patients. We have already evaluated the function and the size. And now we come to the second question, does our patient have ischemia and or viability? Does he have coronary disease is actually the first question. And if he has coronary disease, does he have ischemia? Does he have viability? We do in all these patients an angiogram, immediately angiogram. So you see here an example of such a patient, and he has severe coronary artery disease. An angiogram shows it completely. We can also do a CT scan. These are the raw data that we are post-processing, and from that post-processing, we can see the coronary arteries, as you see here. So this is non-invasive coronary angiography with multi-slice CT. You see that the image quality is very good. This is a normal coronary artery system. And this patient does not have coronary artery disease. If you ask me, what would you do in the heart failure patients? Would you do an angiogram invasively or would you do a CT angiogram? Well, that depends completely on the heart rate. A lot of patients with severe heart failure have a low heart rate, have a high heart rate, around, let's say, 110 beats per minute. And so then the image quality of the CT isn't that good. So if you have that situation, heart failure patient, high heart rate, then it's better not to do a CT scan because the image quality will not be good. You can give beta blockers, but your patient has heart failure, so the LV function will not tolerate high dose beta blockers to lower the heart rate. So the thing is, high heart rate, not good images with CT scan. So that's why I think most of the patients will end up having an invasive angiogram. Okay, we've seen now that the patient has coronary artery disease. So our second question is, does he have ischemia? Should I revascularize? And we can do a nuclear scan, as you see here, but we can also do a stress echo, or we can do a stress MRI. All of that is possible as long as you assess ischemia. The other question that you have is there viability? Do I have a bad function, but is there still a live myocardium, and should I revascularize? Here you see at the bottom row the perfusion. This is actually our patient that we were talking about, and you see there's only the lateral wall that shows in this sort of orange that is still well perfused. But if you look at the top, which says FDG, which is glucose metabolism, you see actually there that there's a lot of orange left, and that means that there is low perfusion in this heart, but there is still metabolic activity. And that shows that it's hypoperfused, but still alive. So this is a good indication for revascularization actually in our patient. We can also do MRI with delayed enhancement. And this is what you see here, the delayed enhancement. On the left is a 4-chamber view. The white on the lateral wall shows the scar tissue. This is a non-transmural lateral infarction. The picture on the right actually shows a short axis, and you see a lot of white ranging from, let's say, 9 o'clock to 2 o'clock in that left ventricle, that circle. And that's almost transmural. So if you want to do viability imaging in patients with coronary disease, then probably you combine the PET imaging with the MRI imaging. And those two give you the infarct size, but also the area at risk. And based on those two, you decide if you want to revascularize or not. We have now discussed about coronary artery disease, viability. We're now going to talk about mitral regurgitation. If your patient has ischemic cardiomyopathy or non-ischemic cardiomyopathy, the question is always, with these dilated ventricles, does he have severe mitral regurgitation? Do I need to consider surgery, or do I need to consider mitral clip, for example? So you need to know your mitral regurgitation. We know also that severe MR affects the prognosis. The top line, the dotted line, is the patients without MR, and the bottom line is the patients with MR. And you see that the cardiovascular survival is much better if you don't have mitral regurgitation. So how do we assess mitral regurgitation? Here on the left, you see a transthoracic echo. You see immediately the mitral regurg. On the right, you see a transesophageal. Now the ventricle is at the bottom and the mitral regurg is going up. So that means going in the left atrium. And this is actually our patient, the one that we started with. He has a bad ventricle, severely dilated, and there is significant mitral regurgitation. Do we need to quantify that mitral regurgitation? Do we need to know exactly how much it is? Well, yes, because in yellow, you see little mitral regurgitation, and in red, you see a lot of mitral regurg. And on the y-axis is shown the survival. So if you have not so much regurg, your outcome is much better than if you have a lot of regurgitation. And that's actually triggering studies like MitraClip to show that if you repair that mitral valve, in this case with clipping, then the outcome is better. So yeah, you need to quantify the mitral regurgitation. How do you do that? With echo. We have very simple ways of assessing. That's on the left panel. You see the vena contracta. That is the jet area as it leaves the effective regurgitant orifice area. And then you see on the right side, the systolic pulmonary flow reversal. What does that mean? That means that the blood is coming from the ventricle, leaking into the left atrium. And if it leaks very far into the left atrium, it goes into the pulmonary veins. And that means that the blood cannot flow in the atrium that's coming from the pulmonary veins. So we get this systolic pulmonary flow reversal. And you see that with the arrow on the right, the white arrow at the bottom, that normally that flow should have been up, and now it's down. And it's down because the blood is leaking back from the ventricle into the atria. That means that it cannot enter the ventricle. Okay, we can quantify that even further. This is the so-called PISA quantification, proximal isovelocity surface area. I'm not going to go into the details, but you see at the bottom EROA. That's the effective regurgitant orifice area. And from the EROA, you can calculate RVol. That's the regurgitant volume. So based on these parameters, you can quantify the severity of mitral regurgitation. You can also do that with an MRI. And this shows an MRI. We put a scout over the valves, and you see at the top the mitral valve, tricuspid valve. You see in the middle the aortic valve. You see at the bottom PV, the pulmonic valve. And you get on the far right this flow velocity encoded images. If we take the mitral valve, you see here the flow velocity encoded images. From that, we can get these graphs as you see on the right side. And there it shows the forward flow, the backward flow, and the regurgitant fraction. This is the best way of quantifying severe mitral regurgitation. But an MRI is, of course, much more complex than an echocardiogram. So in the practice, we use echocardiography in our patients to make the decision, do I need to treat medically or do I need to think about mitral clip or surgical repair? Here we are back to our algorithm. This is the last part. Do I need an ICD in this patient? We know that if the patients have a low ejection fraction, which is less than 30–35%, the MADID-2 trial showed improved survival if you have an ICD. So that is now a class 1 indication. But we have also learned, as you see in this slide here, that 65% of the patients during follow-up of 21 months, 65% in yellow, never have a shock. So you could argue that they don't need the ICD. 35% had a shock. This is also dependent if you look at ischemic or non-ischemic cardiomyopathy. And how can we better assess if a patient needs an ICD? Then you need to think about prediction of shocks. How do you do that? Well, that you can do with an MRI. You see here an MRI on the left panel where you see a huge infarction. All the white is all infarcted tissue in the left ventricle. And from that, we can quantify the amount of scar tissue. And we call that the scar area, and also the border zone where it changes from scar to normal tissue. And the extent of that area is important. The value of that scar area is important. You see here the cumulative event rate, and the cumulative event rate is basically the shock rate with an ICD. And you see that when it's in green, the infarct gray zone is very little, or in red, when the infarct gray zone is a lot, that there is more or less shocks. Bottom line is, if you have almost no infarcted tissue or no fibrosis, the shock rates are very low. And that was shown recently in the non-ischemic cardiomyopathies very elegantly. But also in the ischemic cardiomyopathies, if you have very little infarction, then your indication for an ICD may change. For ischemic cardiomyopathies, this is not in the guidelines. For non-ischemic cardiomyopathies, you see that there is more and more attention to that if we don't have fibrosis, if we don't have scar, that we probably should not give an ICD. I've tried to give you in a nutshell, severe heart failure patient, what do I need? The first step I need, is it coronary disease or not? 60, 70, maybe 80% of the patient have ischemic cardiomyopathy. There you need to know about what is the function? Do I have ischemia? Do I have viability? Do I need to revascularize? If you have a non-ischemic cardiomyopathy, you want to know also the function, and you want to know both for the ischemic and the non-ischemic cardiomyopathy, what about the mitral valve? Is there mitral regurgitation? Do I need to think about mitral repair either by clip or by surgery or not? And the last step is, which of these patients need an ICD? And I think for that, the delayed enhancement with the MRI, giving you the extent and amount of scar tissue, a lot of scar, a lot of fibrosis, you need for sure an ICD. Specifically in the non-ischemic, the Danish trial, as you remember. In the non-ischemics, if there is no scar, no fibrosis, then probably those patients do not benefit from an ICD. What do we do? Complex information you get from imaging, multimodality imaging, develop your algorithm for your place, and that gives you the angle to individualize, to personalize your patient treatment. Again, function, coronary disease, yes or no, mitral regurgitation, yes or no, ICD needed, yes or no. Thank you very much and enjoy the Congress.
Thank you for your presentation. I have some questions. My first question is, what do you think about speckle tracking in patients with preserved ejection fraction and patients with middle range ejection fraction?
Thank you very much. It's a real pleasure to be with you. Although it's virtual, it still feels a bit closer than that we don't do anything at all. So I'm very happy to join you in your symposium. Your question is very important because especially in the patients with preserved ejection fraction, it looks like this ventricle is totally normal. But a lot of these patients, specifically if we talk about heart failure with preserved ejection fraction, a lot of these patients actually have this formation of fibrosis in the ventricle. And basically, if you measure the ejection fraction, it looks all normal. But if you measure the strain, you see that there is already a significant reduction in strain. In other words, the strain seems to be more sensitive in picking up fibrosis in a stiff ventricle, whereas ejection fraction seems normal. It has also been shown in various studies that this has strong prognostic value. The more the strain is reduced, the worse the outcome is. If you talk about the mid-range ejection fraction, also there it's important because these ejection fractions are not completely normal, but a little bit reduced. And then comes the question, how bad is the strain? How much is the strain reduced? And we've seen cases, for example, where the mid-range ejection fraction is almost preserved, and then still the strain is significantly reduced. Again, what is important to realize if you work with strain, that you keep in mind that it reflects the fibrosis in the ventricle, and therefore is a different parameter than ejection fraction. One way to illustrate that even more is if you talk about mitral regurgitation. Your ventricle is doing this, basically nothing, it's standing still. But the ejection fraction looks like 30%. Why is that? Because there's very little blood going forward out of the ventricle, but a lot of blood going backwards into the atrium with the mitral regurgitation. So your ejection fraction says a lot of blood is leaving the ventricle, but it doesn't tell you which direction it's going. And what we want to know is how good is this ventricle in pumping the blood forward. So another way of looking at that is the stroke forward ejection fraction, or the stroke forward volume. And then you also got a quite good idea. But the strain is a good one to measure fibrosis.
Okay, thank you. Ružica.
Thank you very much, first of all, for joining us in this virtual multimodality space. And I would like to ask you a little bit about MRI and the role of MRI in uncovering heart failure, because you have already mentioned fibrosis. So what is the experience and what is your advice regarding MRI in uncovering heart failure etiology?
I think MRI is very important in the workup of these complex patients. And probably, as you know well, the T1 mapping is extremely sensitive for picking up this fibrosis. I see it as this, that you have an anatomical picture, which is the MRI, showing the anatomy, and you can measure precisely the amount of fibrosis. What are then the functional consequences of the fibrosis? That is the reduction in strain. So basically every disease has a component of anatomy, which could be the T1 mapping, if you like, the presence of fibrosis, and then the strain with either echo, but you can also nowadays do it with MRI, is a consequence, the functional consequence of this presence of fibrosis. But if you want to have one technique only that can actually measure the anatomical presence of fibrosis, it's MRI.
And one very short question regarding contrast media in those patients. What do you think?
Can you say that again?
Regarding contrast media, in
okay, yeah. Contrast media, of course, if the patient has severe kidney problems, then it is a bit of an issue. But in the daily practice, if we talk about the relatively preserved ejection fraction, there's not much of an issue. Of course, indeed, when you look at the patients with severe heart failure and kidney function is a problem, then you got to be a bit reluctant with that.
Thank you very much. Thank you.
My pleasure.
One question more. What do you think about lung ultrasound in patients with COVID? I am not familiar with lung ultrasound, but it's now something new.
Yeah, a lot of people start using that. I'm probably much like you. I have not much experience, but the little experience that I have, it's a good marker when the patient comes in with edema. And then you really see this area of fluid as reflected by the ultrasound. So I think it's a good screener for if something is wrong. However, if you don't see anything, the specificity, so to say, is a little bit limited because it can still be that there is something. It seems to work reasonably well, and it's easy when you are at the emergency room and you want to have a look. Now, in the COVID situations with the CT abnormalities, there is a different situation. So there, I think it doesn't mean anything. But I think in the value of including or excluding heart failure, it's pretty good as a first-line screener. You're at the emergency room, you want to have more certainty what's going on with the patient. This is a good one.
Thank you.
My pleasure.